The patient is a 72-year-old pensioner who lives nearby the practice. He is allergic to aspirin. He has had a mitral heart prolapse 10 years ago and myocardial infarction 3 years ago. He is on a list of heart medication including warfarin with an INR of 2.5 to 2.6. The patient is also hypertensive, who is under medication. He is relatively frail and has a low heart rate of 50 beats per minute below at rest. He would like to improve chewing foods with the least invasive treatment options. A little bit of the history. The 3/7 was extracted a year ago at another practice. The experience was stressful to the patient and he had an anginal episode after the extraction. The lower jaw has finished some restorative works, including a removable metal frame denture and 2 posterior crowns, which were documented in the other key courseworks. The upper root treated 2-2 recently has had a fracture at the gum level. However, the patient is not keen on extractions. The examination shows a patient with a partially dentate dentition, and he has been using his old upper chrome cobalt removable partial denture for over 10 years and has been very happy with the comfort. As mentioned earlier on, the teeth 4612 and 22 have been root treated, and the posterior teeth were heavily restored. And of course, as mentioned earlier on, the 22 crown has been fractured recently. The upper arch is currently undergoing some caries control restorative works during the time of examination, where with his lower arch just rehabilitated. The patient has a satisfactory oral hygiene, and he has a decent motor control and is able to maintain his own current denture. The patient is of a skeletal class 2 profile and has a satisfactory range of jaw movements. His 1/7 is over-erupted but does not pose any occlusal interferences. The patient is happy with the current vertical dimension and does not want to have it changed. No palatal tori has been detected, it's not present, and the patient has a satisfactory salivary flow rate. The diagnosis pertaining to this case is the patient's partially edentulous upper and lower arch with a recent 2-2 crown fracture. Discussions of treatment options were given and is listed in the write-up. Definitive comprehensive treatment plan will include caries control and oral hygiene instructions, reduction of sharp edges of fractured tooth 2-2, and conversion to a root stump for an overdenture. This would then be proceeded with the fabrication of a metal frame removable partial denture, which is consistent with the fabrication of a chrome cobalt denture. We aim to emulate the denture design of his previous removable, not only because it was familiar and comfortable, but it is of a Kennedy Class 3 design, where natural teeth are present in between edentulous areas that are to be restored. Unlike Class 1 and Class 2, which are both tooth and tissue-borne, Kennedy Class 3 is strictly tooth-borne, making it an extremely secure removable prosthesis that conform to the 3 principles of denture design: support, stability, and retention. This is also added that the root stumps of 2-2 and remaining 2-4 also lend support and retains the patient's sense of proprioception during function. Maxillary major connectors are avoided as they lack rigidity and therefore do not distribute stress adequately. Instead, we copy back the design of the maxillary plate. There are also direct retainers on bilateral sides, 3, 1 on the left and 2 on the right of the posterior teeth. They are components of the removable partial denture used to retain and prevent dislodgement. All of these direct retainers have components of the reciprocal arm, retentive arm, and in this case, a slight alteration, occlusal rest, which is not present in the previous denture design. Occlusal rests at the anterior region are manifested in the form of cingulum rest. However, they are not as well defined, as adequate support is already achieved by the root stumps functioning as the abutments for overdenture. Reciprocal arms are also present in the denture design, where it resists lateral movement of the prosthesis, resists potential orthodontic movement of the abutment tooth generated by the retentive arm during placement and removal of the removable partial denture, and acts as a guiding plane so that it will contribute to the direction of the path of placement and removal of the removable partial denture. Appointments include the initial consultation with preliminary study models, tooth and mouth preparation if any, master impression stage with the model port and study model surveyed, try-in of framework and shade taking for denture teeth selection, try-in of framework with teeth set up in wax, and finally issuing of the completed removable partial denture and review and maintenance. Meshwork of denture base provides retention of the acrylic base and denture teeth. In this case, there is adequate retention for the anterior teeth without compromising aesthetics. Once completed and fabricated, the chrome cobalt removable partial denture must always be in contact with a wet environment for the sake of the stability and longevity of the acrylic base. It is issued to the patient and allowed to be worn in function and removed at night. Denture care and maintenance is given and reviewed in a week's time. During the review, a minor adjustment was made where the acrylic base that is being supported by the root stump of 2-4 is relatively high and bulky, resulting in poor seating of the palatal plate and incidences of food impaction. It is then reduced and polished, and then placed back in. The patient senses the change and is now extremely comfortable and happy with it. One thing I realize is that the patient is very sensitive to subtle changes. Despite the denture having similar design, he still finds the older denture much more comfortable. This could be a psychological factor. However, the patient is willing to wear and tolerate the new denture.